Very warm welcome to everyone joining us today for this Global Healthy Living Foundation and Creaky Joints hosted webinar titled How Has the COVID-19 Pandemic Affected Patients with Arthritis and Rheumatic Disease? My name is Shilpa Venkatachalam. I am the Associate Director of Patient-Centered Research at the Global Healthy Living Foundation. I'm also the co-principal investigator on Arthritis Power, which is a tracking app and a research registry for people living with all types of arthritis and related conditions. We've been conducting webinars like this now for a few months, and you can access previously recorded webinars. We'll share a link with you momentarily in the chat window, so keep an eye out for that as well. So now on to today's webinar. It's been, I guess, least of all to say, it's been a very challenging year for us all, and we know that for many of us who live with a chronic underlying condition, it may have been particularly challenging to navigate the past few months. On today's webinar, we will share with you some early learnings and insights from a project that we've been working on together with our panelists. Since March, around about the time when this pandemic began. As part of the study, we asked patients questions around COVID-19 testing, about choices that were being made about whether or not to continue immunosuppressive medications, about how patients were managing their conditions with regards to appointments, etc. In fact, many of you have participated in this project, and for that, we thank you very much. I know we're all very eager to get started, so let's dive right in. But before we can, just want to go through a few housekeeping rules. So as you all know, this webinar is being recorded. And for that reason, all audience members will be put on mute. This just helps us to maintain a good quality for our audio recording. The webinar will be posted up on the Creaky Joints website, and we will notify you when it becomes available. We do encourage questions throughout this webinar, and there's a little chat button that you should be able to see on your screen. We encourage you to send your questions at any time during the webinar. You can either use the chat button or the questions button and send that to us. We are going to try to answer all your questions. I know we have a lot of questions, but due to time constraints, we do apologize in advance if you're not able to get to your question during today's webinar. You can always email us if your question hasn't been answered, and we'll try our best to get back to you with an answer. So with that, I'm delighted to introduce to you our fantastic panel today. We have Dr. Mike George, and I know you can see him. He has turned on his webcam, much braver than many of us. He is the Associate Professor of Medicine at the Hospital of the University of Pennsylvania. He is a rheumatologist and also leads this project. Welcome, Dr. George. Dr. Jeffrey Curtis is joining us today as well. He is also a lead on the project and a rheumatologist and professor of medicine in the Division of Clinical Immunology and Rheumatology at the University of Alabama, Birmingham. Dr. Curtis is also the co-principal investigator on Arthritis Power, our research registry for people with all types of arthritis. Arthritis Power currently has more than 24,000 patient members. If you would like to learn more about Arthritis Power, you can always email us, or you can visit www.arthritispower.org. We'll send you all this information as well through the chat box so you can have it at your disposal. Finally, and we have Dr. Maria Danila, also a lead investigator on this project, and rheumatologist and associate professor of medicine in the Division of Clinical Immunology and Rheumatology at the University of Alabama, Birmingham. Dr. Danila is affiliated with multiple hospitals in the area as well, and she too has turned on her webcam, so we're very happy to see her as well. Very warm welcome to all our distinguished panelists, and with that, I will hand it over to you, Dr. Mike George. Take it away, please.
Great, thanks so much, Shilpa, and thank you everyone for being here, and also for everyone who's participated in this project so far. Shilpa, I think you're going to drive the slides here, so I'll let things go. Great. Oh, there's us, looking even better in the photographs than live. Okay, so agenda for today. So we'll go through a brief background and overview and then talk about some of the early learnings and insights from this project. This is an ongoing study, so we'll try and hit some of the highlights of what we learned so far, but much more to come. Talk about some of the key takeaways and what's next, and then hopefully leave lots of time for question and answer, which I think is always the most fun. So let's get into it. So unfortunately at this time, I think an introductory slide about coronavirus is almost unnecessary. I mean, as we've learned over the past several months, this virus is easily transmitted, can cause serious health problems. You know, work on a vaccine is proceeding furiously, but at this time, social distancing, hand washing, mask wearing remains sort of key steps to control and slow the spread of this virus. We know that some people are more vulnerable than others, that older folks are more likely to develop severe illness, but this can range from asymptomatic illness to very severe life-threatening illness. Certain underlying conditions can also be a risk factor, and we're learning more about exactly what those are. Obviously, this group is very interested in how autoimmune disease affects this, and I think there's still more questions than answers. So research is key in understanding how to treat this and how to manage this over time. We've been also very interested in another aspect of researching this and understanding the impact of the pandemic on patients and how COVID-19 in general is impacting the health and the concerns of patients with autoimmune conditions. And so in March, as it became clear that this was coming and a major issue, the Arthritis and Rheumatic Disease COVID-19 project was launched. But as an aside, I will say we were about to launch a project about common infections and how common infections are affected by immune suppressing medications, and hopefully that will be resumed in the future. So look out for that study in the future. But we pivoted to try to tackle COVID-19 as that came to the front. You'll see all of the many partners and people who've been involved in this project, and I'm going to orient you a little bit to the many different facets of this on the next slide. So the Autoimmune COVID-19 project sort of has several arms. So this was a collaborative project of the Autoimmune Research Collaborative, the ARC, of which Arthritis, Power, and Creaky Joints is sort of a key driving member, along with the Vasculitis PPRN for patients with vasculitis, IBD Partners for patients with inflammatory bowel disease, and iConquer MS for patients with multiple sclerosis. In parallel with patient partners and patient input, we developed surveys to deploy, and in all four of these groups in their research networks, we sent out these surveys beginning in late March. We also recruited patients from a large rheumatology multi-state network, BenCare, which you'll hear about a little bit as well, to kind of cover a broad population of patients in a general rheumatology practice. There's a third cohort of patients trying to increase our population of Hispanic and Latinx patients that are represented with a Spanish language survey and outreach to those communities. And thus far, we launched our study on March 28th, and we've recruited over 20,000 people, so 24,000 people total in this study. 2,700 people specifically in the arthritis, power, creaky joints aspect of this study, and an additional study that Dr. Danila will tell you about as well, about telehealth that's been launched, which over 800 people have completed that secondary survey. So lots of interesting things going on. This study duration is a year long. So we started in March, but we had rolling recruitment that's just closed recently, and patients are completing a baseline survey and then repeat surveys every 2 weeks for the first 8 weeks, then it's 6 months, 9 months, 12 months. So we're continuing to collect information over time as the pandemic evolves. There's a number of research questions that we were particularly interested in, and that we knew from patient partners were particularly interested in. So we were interested in concerns about COVID-19, how autoimmune disease affected people's concerns, how their specific medications impacted their concerns and their behaviors around COVID-19. Very interested in how the pandemic was affecting autoimmune disease management, on treatment decisions, office interruptions, telehealth use, infusions. So many questions around those areas. We were interested in how frequently patients with autoimmune disease were being tested for COVID-19, how many were being diagnosed with this. And then what's emerged as an increasingly important issue, the availability of telehealth, and how effective is telehealth during something like this. There was a lot of outreach, a lot of people involved in this study, a number of patient-facing websites to help recruit people and get people interested in the study, social media messaging, and then a number of very important collaborative patient organizations that spread the word of this study, many of which are shown here. So many helpful partners in this study. Okay, so let's get into some of the early learnings and insights from what we've done so far. So as I mentioned, arthritis, power, and creaky joints had over 2,700 patient participants enroll, and a wide number of conditions were represented in this group. So about half of the population had rheumatoid arthritis, substantial number of patients with other forms of inflammatory arthritis, patients with lupus, myositis, many other autoimmune conditions, and then patients, of course, also without specific autoimmune conditions also could be enrolled in this study. There were many different medications also represented. Almost half of the cohort was on a biologic medication or a JAK inhibitor, many patients on methotrexate, hydroxychloroquine, glucocorticoids. So an ability to capture many different types of conditions treated with many different types of medications. One of the most striking things was how much the pandemic has impacted the way that people obtain healthcare for their autoimmune condition. We found early in the study, even in the early weeks of this pandemic, that more than half of people who responded to the survey had avoided a doctor's office visit, that avoiding laboratory testing was very common. And we were specifically interested in medication interruptions. As you may or may not know, the American College of Rheumatology has over time come out with guidelines that recommend not interrupting medications as long as people aren't ill or exposed to someone with COVID-19. But we found that a substantial number of people had stopped medications, especially early on in the pandemic. And frequently that was without a physician recommendation. And of course, people who were ill, many of them stopped medications as well, and which may have been quite appropriate at times. But we're very interested in learning more as time goes on about medication interruptions, infusion visits, and how these things have been impacted by the pandemic, as well as in our follow-up surveys, how does this impact flares of disease and people's health over time? Another major thing that came out of this survey was, and this will be no surprise to this group, is the major barriers to testing. Again, especially earlier in the pandemic, but we know that these issues continue. We found that many people had an illness but were not able to be tested, usually because the test was either not available or not offered. And you can see the many reasons why patients were not able to get some of the testing early on. And this has important implications for even understanding how many people with autoimmune disease have been affected by COVID-19. There's a lot of unanswered questions there. And then we've also been looking a lot into the sources of information about COVID-19. We're so happy about the number of people that are getting information from us here today. It's hard to find information specific to people with autoimmune disease. We found that many of the participants in the study were getting information from news media, from government websites, which are excellent sources of information, but do not always have information specific to people with autoimmune disease. We found that a minority of people had obtained information from their healthcare provider, but that people who had availability of telehealth were much more likely to do that. This is an interest of ours also, and also leads into some of our interests in telehealth, which you'll hear about shortly.
Well, thanks very much, Mike. And just to continue a similar theme in a different group of patients, these are rheumatology patients that are seen in a large physician network of about 250 full-time rheumatology providers. So we sent a very similar survey out to and had almost 22,000 rheumatology patients respond. So as Mike and Shilpa had already pointed out, if you were one of those that took a few minutes to fill this out, then we certainly want to thank you. You know, there's a lot of insights we derive from this kind of research. I know surveys are often not the most exciting thing to fill out, but they really help the whole community. So we appreciate folks donating their time to be part of this global endeavor to try to get a handle on, you know, what is known and what needs to be known in terms of COVID and best practices, and helping people be safe and accumulate evidence to know how to do that. So in this group of people, the folks that responded had a great likelihood to have rheumatoid arthritis. That's the blue in the pie chart on the left. There was also good representation for people who had lupus or psoriatic arthritis. On the right-hand side, and the thing that makes this part of the analysis a little bit unique, is there was a comparison group of people who have osteoarthritis. So this typically doesn't have very much inflammation in it, and it would be relatively uncommon for people who only have osteoarthritis to be treated with immunomodulating drugs. That's not a treatment that we would typically use for someone who only has osteoarthritis, or osteoporosis, where likewise these are people that are typically not on immune affecting medications. Next slide. So this is the breakdown of the different therapies that the people with autoimmune conditions were on. So biologic DMARDs, drugs typically given by injection or by infusion, that was more than a third. Janus kinase inhibitors, so those are oral pills given once or twice a day. Methotrexate, hydroxychloroquine, about a quarter of people. There's been a huge media buzz around whether hydroxychloroquine might prevent COVID or actually be a treatment if you got COVID. Our president, you know, announced that early on. There was kind of a run on hydroxychloroquine, even though the data probably was nowhere near what would have been appropriate for any sort of recommendation. Nevertheless, you know, so a quarter of people were already on that therapy. I know that anecdotally, some of my patients actually had a hard time finding hydroxychloroquine. There was such a run on it. And then about 21% of people were on steroids like prednisone, and 29% that were on NSAIDs, Celebrex, ibuprofen, things like that. Next slide. So one of the key findings that we learned is to look at various people's you know, attitudes, behaviors, etc. So it was interesting because the comparison here in blue is people who don't have an autoimmune condition versus orange who do. And what you'll see in that first set of bar graphs is the amount of concern about COVID-19 was in fact pretty much exactly the same. People were worried regardless of whether they had an underlying autoimmune condition or they didn't. What was strikingly different though is that if you had an autoimmune condition, the next set of bar graphs, that you were much more concerned about your health condition affecting that concern. Basically, you were worried that because you had rheumatoid arthritis or lupus, etc., that condition made you more at risk, made you more vulnerable. And much like Mike had described just a few minutes ago, we asked the same question, you know, have you stopped taking your medicines? And about the same proportion did. About 14% in that survey had quit taking their medicines, and most of it not under the advisement of a doctor. And so I think that also relates very much to being concerned about the disease you have and perhaps some of the treatments that you're on for that disease. A very high proportion of people, more than half, had skipped doctor visits or had missed some lab tests that they were supposed to have. And then finally, something that we started to ask about, you know, more than a third of people, regardless of their health condition, had started having telehealth visits done. This was a survey that was deployed at its latest at the beginning of May. And so Dr. Danila is going to talk to us now about what additional has been learned about telehealth or telemedicine visits as really an unprecedented way to deliver care that before COVID was almost unheard of in the field of rheumatology.
Thank you, Jeff. So as Jeff mentioned, there is no surprise to this group that COVID-19 has spurred deployment of telemedicine to a scale that we have never seen before. And part of the survey that we deploy was your help. And again, I want to join my colleagues in thanking you for being a participant in this endeavor, has been to understand what patients think about telehealth, what is done well through telehealth, and what may need some improvement. We started deploying the telemedicine survey in the month of June, and over a couple of months, we collected approximately 880 responses. We found that many of the participants to the survey reported that their clinicians were offering telemedicine visits. And among those who were offered a telemedicine visit, 3/4 of them actually had a telemedicine visit. One of the questions we were primarily interested in is to understand the experience that a patient had when they encounter their doctor or nurse practitioner or physician assistant through a telemedicine visit for the first time. As we know, delivering home health, so home-based telehealth, it was just pure novelty at the beginning of the pandemic. And we used a simple question and asked the respondents to rank their experience with a telemedicine visit on a scale from 0 to 10, where a 0 is the worst possible visit and 10 being the best visit. And we were very happy to hear that 70% of the participants ranked their experience, their satisfaction between a 7 and a 10. Few other things that we learned through the telehealth survey was that there were specific scenarios that patients thought they would, that telehealth was a preferred way of delivering care. This type of scenarios were things like when they needed to discuss test results with their clinician, or when they were having a routine visit for at the times when they were feeling well. The patients that responded to our survey also told us that they preferred in-person visits for new symptoms when they were planning to change medication or during a flare. Next slide. So what are the takeaways from this project? Probably most importantly is don't stop your medications. You know, currently there is no evidence to support the idea that while patients that are immunosuppressed are at high risk of getting COVID, there is no data to support that there is a need to stop an immunosuppressant medication. If you consider stopping a medication, it's always best to talk to your clinician. Having a continuous discussion with your clinician about your experience with your chronic condition and making sure that you control your disease properly is very important at this time, as there are quite a few gaps in care that have been observed or exacerbated since COVID-19 started. Many patients with autoimmune conditions take medications that need close monitoring with blood tests and frequent visits to evaluate for various side effects. Again, it's really important to stay on top of your chronic condition, and it's important to keep a dialogue with your clinician. We also learned that, and need to remember that COVID-19 is a new disease. We're still learning a lot of new things every day, and our knowledge is expanding exponentially, probably faster than ever before in the history of medicine. There are several aspects or characteristics that make one more at risk to poor outcomes from COVID. including including advanced age or immunosuppression or other comorbidities. So what's next? Stay connected. Arthritis Power has a patient-centered registry. There is a website on the screen, www.arthritispower.org, where you can learn more about what Arthritis Power does and is, and how to get engaged in this patient community, which has generated a lot of fantastic studies. There are webinars like this, patient engagement webinars that have been conducted over the last few months, where we describe the latest findings in the cutting edge research that has been done by partners from GHLF and Cricket Joints. There are many studies that we're continuing to think about doing. We've been lucky to have the ability to contact patients and to hear from them as to what's important to study at this time. There are further studies planned on vaccinations and telehealth, and there are a lot of things that we all want to learn as we move forward with this health response to the pandemic. There is also a patient support program that was established mid-March by GHLF and Cricket Joints, where both patients with autoimmune diseases, but also patients with other conditions, can go and learn about COVID and symptoms, about a way to stay healthy during this time, and about how to prevent contracting COVID. Thank you. Shilpa?
So big thank you to all our panelists. That was great information. We have a lot of questions coming in, so please keep them coming, some great questions. And here we will try and get to all your questions. Just as a reminder, this webinar is being recorded, so you can access the recording if you need to refresh yourself with any of the information that's been provided during this webinar as well. We will send a notification to everyone who registered about this recording as well. So let's move on then with our questions. There's a ton of questions on medications. So why don't we start with a question on medications first? And perhaps I can start off with a question for Dr. Curtis on medications. And the question, Dr. Curtis, for you is, do immunosuppressive medications that many of us take for our disease, whether that's rheumatoid arthritis or psoriatic arthritis or any of the other conditions that many of us are dealing with, do they offer any protection from coronavirus, or in fact, do they put us at increased risk for developing or catching the infection? Dr. Curtis?
Yeah, so that's a great question. And of course, that's one of the hottest topics that everybody, doctors, patients, and all of us alike would like to know the answer to. There was a lot of interest initially about hydroxychloroquine or Plaquenil, same thing. You know, there's been a number of studies that have been done that really have not panned out or proved much that Plaquenil helps either prevent infection from coming, or that if you have infection, that it speeds recovery. So there's still a number of trials that are evaluating Plaquenil, but it doesn't seem like that's likely to pan out based on the evidence that we have. In contrast, however, there actually are a couple medicines that either appear to work or that may well help, that there's some positive news. So there's been probably the greatest enthusiasm for Actemra and Kevzara. So those are two rheumatoid arthritis medicines that are used for a few other things, but because sometimes when people get sick with COVID, their immune system kind of goes crazy. Essentially, it's the immune system out of control, that medicines help keep the immune system in control, like those two, and perhaps others, that they actually help people that have some of the most severe manifestations of COVID, you know, in the ICU, on a ventilator. So there's ongoing studies of a number of our therapies, mostly rheumatoid arthritis medicines like those two. There's actually a trial looking at steroids where for people that, again, are really sick in the ICU and needing oxygen, that steroids actually help. So although sometimes we worry that an immune affecting medicine might worsen or disease or cause increased risks, if you got COVID and you're quite ill from it, it looks like some of our immune affecting medicines help. And then the most recent thing that we've learned just in the last several days, so another rheumatoid arthritis medicine, Olumiant or baricitinib, looks like in people, again, who are sick, that it actually shortens the time to recovery. So the Olumiant is in a family of medicines that the two others in RA that are in that family are Rinvoq and Xeljanz. So those three are kind of in the same family of medicines. And Olumiant was shown to reduce the time it took to recover if you got COVID. That said, it only shaved 1 day off of the recovery time. So, not a big effect, but nevertheless, it's certainly an option to consider. It's not FDA approved for that at this point, but the results from that trial are positive. And that's about as much as we know at this moment in time in terms of some of our immune system affecting medicines actually helping if you got sick and were quite ill, requiring hospitalization for COVID.
Thank you, Dr. Curtis. That was great information. And again, I suppose the key message there is that we're learning more and more about coronavirus as the months go on. The next question, so there's actually quite a few questions also about something that's greatly anticipated, the vaccine, and people are very hopeful about this, about a vaccine. So I'll try and collapse two or three different questions into one, and this is for you, Dr. George. So the question about the three questions actually about the vaccine, and you could take either one of them or all of them. One is about whether or not people with autoimmune conditions might be included in clinical trials for the vaccine trials. The second question is about whether or not the vaccine is expected to be what they call a dead vaccine or a live vaccine. So perhaps we can start with those two questions.
Sure, and I think those questions get into, I think the things that we care about are, will the vaccines that come out be safe for people with autoimmune disease, and will they be effective? I think those are sort of the two key questions, and I think the bottom line is we might need to learn more as time goes on to know all the answers to that, and I think it's going to be really important to get into some of the specifics of these trials. As far as I'm aware, the great majority of vaccine trials going on are not with live vaccines, and so from a safety standpoint, there should not be a risk of getting COVID-19 from any of these vaccines, regardless of immune status. And we will have to learn more about whether any of these could potentially stimulate the immune system or make someone sicker for their autoimmune disease. That seems unlikely, but I think we're going to have to learn more as we see which vaccines come out. In terms of efficacy, so in general, most of the phase 3 trials, the large studies of these vaccines, are not including patients who are on immune suppressing medicine. So from most of the large studies, we probably won't know exactly how being on an immune suppressing medication impacts how well you respond to a vaccine or how protective it is. Of course, any protection is better than no protection, and no vaccine is 100% in anyone. So I think we're going to have to sort of see what comes out with the data, and then it is going to be important to continue to study once the vaccines do come out and people with autoimmune disease start getting them in larger numbers, to start to study this. And Dr. Curtis has studied vaccines in other settings in people with autoimmune disease. He may be primed to do this, but to learn about how people with autoimmune disease respond. I think we'll learn more about the safety, but I'm confident that people will be able to get this, and I'm sure that it will convey at least some protection, but we need the data first.
Thank you, Dr. George. It's a topic that a lot of patients are interested in. And if you are wanting to learn more about that, we just at Creaky Joints, we've just published an article on vaccines related to COVID-19 and what you should know as someone with an autoimmune condition. So you can access that article by visiting us at creakyjoints.org. In addition, a few months ago, perhaps even a year ago, we had done another webinar like this with an expert on vaccinations and how vaccines work. And that too is available. A recording of that is available on Creaky Joints. So if that's something that you might be interested in, then do please visit us or reach out to us and we can share that information with you. Thank you, Dr. George. Next question is for Dr. Maria Danila. And this has to do with the upcoming flu season. I think people want to, again, there are 2 or 3 different questions and I'm collapsing them into one question here. So I think people are interested to know if there's any way to tell the difference between the flu and coronavirus. That's the first question. So what symptoms perhaps might indicate one versus the other? The second question is also about flares. So a lot of us with autoimmune conditions experience flares, and many of the symptoms that we experience during a flare are similar to that experienced when we have the flu. So what is the safest way to go about this? How do we know when to see our doctor and when not to? Could you talk a little bit about that?
Yeah, certainly. Thank you for those questions. So regarding the difference or commonality between coronavirus and flu, we've heard a lot how coronavirus symptoms usually start pretty gradually, while flu usually sort of hits you all of a sudden. The most common symptoms for coronavirus are fever, cough, the terrible fatigue, and shortness of breath. And while these symptoms are also occur with flu, in general, patients don't get as much shortness of breath or difficulty breathing with flu as they would get with coronavirus. Flu usually goes away in few days, maybe a week. Coronavirus, COVID-19 particularly, tends to linger along a little bit longer. And we've heard from patients that even months after the disease, they may have spells where symptoms come back. Perhaps one of the most interesting symptoms that has been put forward as a differentiator between COVID-19 and flu has been this sudden loss of smell and taste. And while other respiratory viruses and such as influenza, that can occur, usually that's pretty uncommon. So that's sort of one of the symptoms that sort of stand on top of my mind as a major differentiator between the 2 illnesses. In terms of a flare, I think, and how to differentiate between the fatigue or arthralgias and other symptoms of a flare, for example, of lupus or rheumatoid arthritis, and what COVID-19, especially what's being called the long haulers COVID-19 symptoms, it's really difficult. I mean, the gist is, it's very difficult to make that difference, and that's because after COVID-19, for many weeks and months thereafter, some patients continue to experience fatigue, continue to have some cough and difficulty breathing, and that's perhaps due to some of the lung damage that occurs in people that have more severe symptoms. So it's, I think at the end of the day, when in doubt, one has to call their clinician and have an open dialogue about what they feel. I think patients, are the most knowledgeable about their disease, and especially those who have had flares before. Usually flares tend to be similar in many patients, and that how the how your flare manifests itself, year after year may be similar compared to what the symptoms from COVID-19 may be.
Great information. Thank you so much, Dr. Danila. I'll just add one quick question there. Someone's asking about whether or not it's safe to get the flu vaccine and the pneumonia vaccine as these are all patients in vulnerable groups. Any advice on that?
Yes, certainly. Get your flu vaccine now. So the issue is if there hasn't been this is the year when to get the flu vaccine. I think the potential of getting flu at the same time as COVID-19 is certainly there. I think we've learned from countries in the Southern Hemisphere, like Australia, that their flu season has been worse this year compared to what they usually experience in the months of August. So I think right now, vaccination against flu, it's paramount. It's of paramount importance.
Great, thank you. So very important to get your flu shot if you haven't already, and to speak to your doctor about that. We have time for maybe 2 or 3 more questions. I see there's a lot of questions, and again, apologies if we haven't gotten to yours. There are a few questions I'm seeing also about, questions around whether or not one should go to the gym or to a cinema, etc. And I think this is a good time to let our audience know that we do have a part 2, if you might, of this webinar coming up in the first week of October. You should all receive a notification about that. And that webinar has a lot of information we'll be sharing about how to make decisions, practical decisions, sort of how to weigh risks and benefits of, say, meeting your family or going out to a social gathering, etc. So do join us for that one. We'll answer questions about things like whether or not it's safe to go to the gym, etc. during that webinar. All right, so moving on, next question is for Dr. Curtis again. So Dr. Curtis, I know you alluded to this in your previous answer when you talked about immunosuppressive medications, but there are specific questions about whether just merely having an autoimmune condition puts someone at an increased risk to contract the virus. And then secondly, is there any data that shows that people with autoimmune conditions who then get coronavirus are likely to get sicker or then likely to be hospitalized at a rate higher than the other population, general population?
Sure, those are 2 great questions. So the first question is, somebody who has rheumatoid or lupus or a condition like that, are they at higher risk to get coronavirus? So I've not seen, great large-scale data. I think the answer is probably. Even in the absence of data, it is exceedingly common and frankly expected that the risk for infections for pretty much all kinds of infections is increased in people who have an autoimmune disease. And certainly who are taking the usual medicines. So I think that given that coronavirus is probably not an exception to the general observation that people with autoimmune disease have a higher infection risk, there's no reason I would expect that coronavirus would somehow be an exception to that general observation. That said, I think sometimes people worry perhaps even more than is warranted. So for example, on average, the typical woman, say with rheumatoid arthritis, who's perhaps 50, her risk of having a hospitalized serious infection might be 3 or 4% over the course of a year. So sometimes people have a very exaggerated notion of, what are their risks to have a serious infection? So while we don't have great data specific to coronavirus, yes, pretty much all infections are increased in somebody with autoimmune, but they're often a lot lower than people might intuit. Your second question, if you get coronavirus and you have rheumatoid or lupus, is it more likely to be severe? that we actually do have some data for, particularly for rheumatoid arthritis, where there's just more people, say, than compared to lupus. So yes, you are at a higher risk to have more severe manifestations, to be hospitalized, etc. So I think that the cautions that mostly common sense would tell us, you know, hey, if you have an autoimmune disease, you're probably at higher risk to get it, and you're more vulnerable to have a bad outcome. I think that's going to be justified, and we do start to see some data that actually proves that to be the case.
Great, thank you, Dr. Curtis. And someone else has actually asked about conditions that are not necessarily of an autoimmune kind. So, for example, osteoarthritis. Is there any indication to suggest that people with osteoarthritis might be at higher risk for coronavirus?
No, I really wouldn't expect so. So that's why in that slide that we showed just a few minutes ago, we sort of lumped different diseases into, you know, autoimmune or high inflammatory conditions where immunomodulatory medicines are common. Osteoarthritis, which of course is the absolutely most common form of arthritis. You know, if most people think about any kind of arthritis, you know, osteoarthritis or the wear and tear degenerative kind of arthritis, that one is the most common. There's no reason to think that that arthritis would put anybody at increased risk. So no, if you have that type of arthritis, I would not have much in the way of fear that you're at any higher risk than the general population.
Great, thank you. Dr. George, next question is for you. And again, I'm trying to get to everyone's questions, so I might collapse questions and sort of field them as one question. So I apologize if your question gets lumped in with other people's questions. But Dr. George, could you talk a little bit about the difference between the COVID-19 test and the antibody test? We hear both these terms being thrown around quite frequently these days. Would you be able to explain and brief the difference between the two?
Sure, Shilpa, I was just surprised because that wasn't a multi-part question, so I wasn't sure how to answer a single part question. Yeah, I mean, the most common test, and when people say COVID-19 tests in general, they're talking about, you know, the nasal swabs or the saliva test to really detect the virus itself. So that's looking for active virus. That's detecting, do you have coronavirus right now? Although you can continue to shed the virus for a little bit, or particles of virus for some time, so those may remain positive even for a few weeks after the illness is gone. The other testing, which has there's been buzz about, is antibody testing to see, did you have the virus in the past? So this is looking to see, do you have antibodies in your blood suggesting that your body has seen coronavirus and fought it off. I think that there is more to learn about those tests. I have in general been recommending that my patients not get those, because I think that there's still variability in quality. We still don't necessarily even know what they mean. Are the antibody levels, you know, how do they cross-react with other things? Are you actually protected? I think everyone should be protecting themselves anyway, wearing masks, doing social distancing. So, but those, we may learn more about those in the future, and maybe the recommendations of that will change in the future. But that's the major difference in those two tests.
Great, thank you. Dr. Danila, you spoke briefly about telehealth, and actually there are two questions here about whether or not telehealth is here to stay. So, you know, once we get through this pandemic, and I hope we get through it soon and safely, as safe as possible now, is telehealth something that might continue on as a you know, route of care? Could you talk to that, please?
Sure. Thanks for that question. So I think it's you know, difficult to predict the future, but I think it's fair to say that there has been a lot of interest from all stakeholders, from patients, from clinicians, from insurers, from policymakers into this topic of telehealth. And there is actually bipartisan support for legislation to expand telehealth and to allow telehealth to remain in play in some form after COVID-19. In fact, during this 4 or 5 months since telehealth, since the COVID-19 just spurred the expansion of telehealth, we've seen the insurers and Medicare come up with policies expanding the access to until the end of 2021, actually, for telehealth services. So I think it's safe to say that through next year, we'll continue to have telehealth. I think it's also an interest to expand practice through telehealth over state lines. There is interest to better understanding telehealth, and particularly the delivery of telehealth in patients' homes. I think one of the issues that we've seen happening, despite trying to ensure continuity of care, is that broadband internet is really not as expanded as we would like it to be in the United States. And many patients, particularly older adults, live in rural communities, and they may not have access to broadband internet and or smartphones, for example. So I think there is an interest in understanding the disparities in trying to develop interventions to mitigate these disparities that may become more acute now, when the availability of in-person visits has been somewhat diminished, particularly due to the stay-at-home orders and so on. So I think we'll have to see what the future brings, but as we move forward, we should be able to still have telehealth for particular situation available for patients to ensure the best possible outcomes for chronic conditions.
Great, thank you, Dr. Danila. So I think we're sort of approaching the top of the hour, but we have one more question. And again, actually, this question has been asked by multiple people. People are asking, for example, someone has said they have a colonoscopy scheduled, which has been delayed for months now. Someone else has asked about blood tests and lab work that needs to get done. Other people have asked about starting a new medication. By and large, I know that's a lot of different questions, but by and large, what is the advice for patients about keeping appointments, getting tests done, etc.? And perhaps we can get input from all three of you, since this is our last question. So we'll start with Dr. Danila and then move to Dr. George and then to Dr. Curtis. And any final words from you all will also help.
Certainly. So I think it's fantastically important to have maintenance of care for chronic conditions, and primarily, and also in addition, preventative care. I know in my office, we've implemented new ways of patient
Please go ahead.
I was saying that in my office, we've implemented many ways to keep the patient safe and to ensure that at every step of the way, the access is maintained to preventative care, because we don't know how long this pandemic would last. we all hope it's going to be it's going to end sooner rather than later. But canceling appointments right now without doctor's input or with the healthcare provider input would be really unadvised. So please talk to your physician or other healthcare provider if you consider to change a date for a procedure or lab test.
Great, thank you. And Dr. Curtis and Dr. George, any other input and final words from you both?
Sure. No, I mean, I agree with what Maya said. I mean, we have, I know at our institution, done a lot to try to make the experience safer. Many labs are now by appointment only to space people out. And so I think that there's ways to get healthcare safely. I mean, on the other hand, it's worth having a conversation with your doctor about, okay, is this test needed right now? Can it wait? Do I feel comfortable doing this? Are there things that can be done by telehealth just as well? If you can get equally good care another way, I think that's a reasonable thing to discuss. So I think it's a very case-by-case basis also, but I agree. I think we're now delivering healthcare in a much safer way, and I feel, at least at our institution, that when you come in our doors, it's a safe place to be.
Yeah, and I think I would echo the comments of my colleagues. I mean, if you need to come in, and I think that's a question, do I need to come in? You don't have to skip it, but you know, if a phone call will suffice for certain things, that's appropriate. Great, then do that. Practically, you know, if we thought this whole thing was going to be gone in 2 months, then some things could wait. But, you know, that was a long time ago that people may have assumed that, or myself included. So we don't know when this is going to end. And I think skipping or missing things is a bad idea. And as both Mike and Mayo said, most healthcare providers are really careful and really have been thoughtful about this. And I think if you have any questions, it is perfectly reasonable that you call and say, tell me what your screening procedures are. Tell me what you're doing to protect me. If you get a wishy-washy answer, I wouldn't go. I'd say, you know, convince me that this is safe. And if people, you know, are giving you reasonable answers that it's clearly very thoughtful about what they've done to protect your health, then I think probably the risks and benefits in almost all cases are going to be to get the health care that you need, because people are looking very thoughtfully after your safety. To the best of my knowledge, you know, this has been ongoing for 5 or 6 months now, and at our institution, there hasn't been anybody who has contracted COVID infection as a consequence of showing up to clinic, you know, with the screening procedures put in place that we now have. Of course, I can't say that for every healthcare facility in the country, but I think most of them are quite careful and thoughtful about doing the right thing and going the extra mile to keep people safe.
Wonderful. Thank you so much for that very, very important information. And thank you to everyone. Just a few things before we can wrap up for today. At GHLF, we started and launched a patient support program for people living with chronic illness to help them navigate the coronavirus pandemic. So many of the questions that you've asked today, and actually thank you for those, because as a patient myself living with an autoimmune condition, I share many of your concerns as well. So your questions helped me as well. But we've set up this program mainly to answer and respond to your needs, and so that we're with you together in this pandemic and we can continue to respond to your concerns. So please don't hesitate to send us any additional questions that you might have. You can always email us, or you can visit www.ghlf.org to learn more. So once again, thank you very much for a very robust discussion today, to our panelists and of course to our audience members for all their questions. Again, our sincere apologies if we haven't been able to get to your question. We tried our very best, but given that this is an hour, we really couldn't cover all the questions. But do stay tuned for our next webinar, which is also on coronavirus, and you will be receiving an invitation shortly for that webinar, scheduled for, I think it's October 1st. With that, I think we can wrap up for today. We know the pandemic continues on and concerns continue on. And we want to end this by saying that we're in this with you and together we will get through this. Thank you again for today and for taking the time to join us on this webinar. Have a good rest of your day.